Hello. Our module for today will focus on food-borne diseases and vector-borne, vermin-borne diseases. However, the overview rather, on prevention and control of communicable diseases will be discussed for this particular lecture. So for the objectives of the module for today, at the end of the session, the students shall be able to, number one, explain core principles in the prevention and control of communicable diseases, with special emphasis on breaking the links in the chain of infection. Number two, we will enumerate different preventive measures related to proper food handling and preparation, which align with the control of foodborne or vehicle-borne diseases. We will discuss basic public health concerns on controlling vector-borne, vermin-related diseases in the context of environmental health. And lastly, we will identify common strategies of existing national health programs aimed to control and prevent priority communicable diseases. I am slightly deviating from the original topic for this session in the sense that for you to understand control of vector-borne or vermin-related infections, including foodborne, waterborne diseases, you need to have a good grasp of the overall strategies employed in terms of prevention and control of communicable diseases. So let's talk about communicable diseases in general. Communicable diseases are characterized by the existence of a living transmissible infectious agent and its interaction with the human host in a given specific environment or precise habitat. If you will recall, this is actually a reflection of the ecologic triad of disease causation, wherein the interaction of the agent and the host would often happen in a given environment. The ability of the host to resist the infection and the capacity of the infectious agent to incite cellular and tissue damage in a particular host would really look into the balance between the forces of infection and the forces of resistance. Communicable diseases are illnesses that arise from the transmission of an infectious agent or its toxic product from an infective person, animal, or reservoir to another susceptible host, either directly or indirectly through an intermediate host, vector, or environment. Now, when we talk of communicable diseases, they do not happen in the same manner across individuals. Rather, communicable diseases happen in such a way that there will be differences based on susceptibility characteristics of the human host. Once exposed, people with, as well as people without clinical or biological signs of infection, are capable of spreading the disease to other individuals, and these are what we refer to as your carriers. Now, when we talk of carriers in the context of medicine, we have identified several types of carriers. Again, a carrier is an individual who harbors the infective agent without showing signs of disease, but is capable of transmitting the agent to other individuals. Now, there are different types, the first of which would be a chronic carrier. A perfect example for this would be your hepatitis B virus. Your hepatitis B virus is something that you acquire through exchange of bodily fluids. Often it is transmitted via sexual intercourse, transplacental transmission from a pregnant mother to the growing fetus, or it could be through blood transfusion. Now, hepatitis B is an infectious agent that exemplifies that type of transmission. Normally, your hepatitis B is a very lazy virus in the sense that it can remain dormant for decades in your liver, causing no symptoms, but one day it will just wreak havoc and result in liver cirrhosis that can further precipitate what we refer to as your hepatocellular carcinoma. Ergo, when we're talking for hepatitis B, this is one of the first vaccine preventable malignancies. If you are familiar with the expanded program on immunization, a newborn baby before leaving the hospital or the healthcare facility ought to get the first dose of the hepatitis B vaccine. In the same manner, all pregnant women are 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 ideally subjective to hepatitis B screening because you want to make sure that a pregnant mother will not undergo transplacental transmission of your hepatitis B. This is an example of a carrier that has the capacity to result in malignancy. Then you have your convalescent carrier. This is exemplified by infectious processes that become more infective, meaning to say, the ability to infect other susceptible hosts would become more apparent during the period of recovery. An example of which will be your varicella or your chicken pox. Whenever you see a person with these generalized vesicular rashes, that are the rash and the rashes are often accompanied by low grade to moderate grade fever. This is what we refer to as your chicken pox. When you see those fluid filled vesicular rashes, they're not yet as highly infective or as contagious versus once the vesicles rupture and you see those umbilicated ulcers. During this period, they are now on the road to recovery. But during that period of recovery, they remain to be highly infectious. That is why when you see patients in your private clinic suffering from varicella or from chickenpox, as long as there is a single vesicle or any weeping lesion where you see that there is still some fluid filled areas, even if they're already on the road to recovery, we still isolate them. We restrict their movement because there is a higher probability that they will transmit the virus to another individual. Again, that is your convalescent carrier. Then you have your incubatory or your precocious carrier. This is when a person who manifests no clinical symptoms would still have the capacity to transmit the infection. At the top of my head, what I would think of an example for this would be your human immunodeficiency virus. For all patients who are sexually active, and we advise for them to get tested for HIV. If you test negative for HIV, let's say, for example, on September, you test negative for HIV. From September until the next consecutive 6 months, there is a possibility that you are still in the window period. And if you still engage in unprotected sex, even if you are HIV non-reactive or HIV negative come September, anytime from September until 6 months thereafter, there is a possibility for the HIV to be passed on because you are in that period of incubatory carrier state, or there is still period of incubation. Then there are those which you have your asymptomatic or your passive carrier. A classical example of this will be your Typhoid Mary. I want you to read on Typhoid Mary, but in a nutshell, Typhoid Mary was an American. I can't remember if she was what exactly her work is, but she used to work from several facilities and she would prepare meals. But the thing with Mary, she unfortunately has Salmonella typhi. Salmonella typhi is a bacterium that causes her typhoid fever. And normally, when every time you defecate, there is a possibility for you to release the bacterium from your fecal material. And if you do not, let's say, practice proper hand hygiene, let's say after you use the toilet, after you defecate, you did not wash your hands, and then inadvertently you prepared food and someone eats that food, there could be fecal-oral route of transmission of your Salmonella typhi. And that's exactly what happened to Typhoid Mary during her time. So that is an example of your asymptomatic or your passive carrier. For academic purposes, again, I would like you to do further reading on these types of carrier states. Now, when we talk of communicable diseases, whether we're dealing with waterborne diseases or what we refer to as your vehicle-borne infections or your vector-borne infections, they are all subsumed under the umbrella category of communicable diseases. And it is imperative that you know the life cycle or how the disease would normally propagate from its period of incubation to uh, the transmission. Knowledge of the natural history of disease is important for us healthcare providers to initiate preventive and control measures. We do recognize that there will be infections that would have a very rapid type of transmission versus those that could spread insidiously. For example, I want to show you a picture of this. I've only seen one case of meningococcinia when I was doing my residency training at the Philippine General Hospital. As a family and community medicine resident trainee during our second year of training, we have a 2-month rotation in infectious diseases as the Research Institute for Tropical Medicine. I vividly remember seeing a baby, a toddler rather, who was presented at the emergency room with this type of violaceous rashes. For the medical technologists in the room, if you do a skin scraping of these lesions, these violaceous lesions, and you find under the microscope your intracellular diplococci, you would know that this is your meningococcinia. Now, the thing with your Neisseria meningitidis, it is a very fatal type of infectious process. Once you get exposed, if you are not able to give the definitive management within the next 72 hours, there will be a higher probability for mortality. Now, why am I sharing this story with you? Because whenever you encounter meningococcemia, this is one of the notifiable communicable diseases that we have to report to our registry here in the Philippines. The thing with meningococcemia, it's very fatal. Anyone who gets exposed to meningococcemia would need to get post-exposure prophylaxis. I vividly remember when I saw this patient at the RITM years ago, all of us in the emergency room, from the security guard to the nurses to the med tech to the doctors to the bantay or to the other relatives of the other patients, we were required to get prophylaxis against meningococcemia because meningococcemia is a very um, communicable, highly communicable infection that can spread rapidly to other individuals. And if you are not careful, if you um, miss out on the diagnosis, it can lead to premature demise of people who were exposed to your Neisseria meningitidis. In contrast, there are infections that would develop insidiously. For example, among people living with HIV, with AIDS defining um, opportunistic conditions. For example, this is another type of lesion that you might encounter among your PLHIV, and this is actually your Kaposi sarcoma. Your Kaposi sarcoma is a type of malignancy commonly seen among immunocompromised individuals who are suffering from from HIV infection and or AIDS. But once they develop your Kaposi sarcoma, this is one of those what we refer to as your AIDS defining conditions, regardless of your CD4 count levels. So this is again another example of a communicable disease, but with an indolent, insidious type of disease causation in terms of transmission. Now, this is the chain of infection. Whenever we talk of communicable diseases in general, you need to understand the interplay of all of these links to the chain of infection. The links would include the agent. So these could be an etiologic agent. It could be your bacterium. It could be a virus. It could be a parasite. It could be a protozoan. It could be a helminth. And then we also consider sometimes there would be communicable diseases or infectious agents which will require a reservoir. And how does this etiologic agent leave a sick individual? That will pertain to the portal of entry. Then how is this transmitted to the next susceptible individual? These links would now include your transmission route as well as your portal of entry. And of course, what are the risk factors that make a susceptible host at a higher risk for acquiring the infection? Any preventive or control measure aimed to limit the burden of communicable diseases. All interventions would often look into these links and initiated that will break the link of the chain of infection. I've mentioned, let's start with all of these links, beginning with the infectious agents. When you go to microbiology and parasitology in sophomore year, you would meet a variety of infectious agents that are notorious in causing your communicable diseases. This will include your bacterial species, your viruses, your protozoans, example will be your amoeba, your fungi, your Rickettsia, your prions. Prions are proteinaceous materials, very similar to the viruses. And of course, you have your helminths or your worms. When we talk of reservoirs, they are basically not they may harbor the infectious agent, but they do not manifest any clinical symptoms. You could have human reservoirs, animal reservoirs, or environmental reservoirs. Just to cite examples for these, a perfect example of a human reservoir would be for your variola. Your variola or your smallpox is a viral infection that has been eradicated already from the face of the earth. What is the difference between eradication and elimination? Basically, when we're talking of eradication and elimination, these are concepts related to disease prevention and control of communicable diseases. Elimination and eradication would entail zero incidents, meaning to say there will be no new cases already. But the main difference between elimination and eradication would entail there would be no more need for any active intervention to maintain and sustain that zero incidence. In contrast, when I say elimination, we maintain and sustain the zero incidence rate through active interventions. Variola or your smallpox is the very first infectious process that has been eradicated from the face of the earth. Meaning to say, we no longer transmit this virus and there are no active interventions being done to maintain and sustain that zero incidence rate. Back in circa 1960s, when variola was still evident, because of the vaccination process, the world was able to achieve what we refer to as your herd immunity. Herd immunity refers to the protection that we get from protected from let's say vaccinated people. What do I mean by that? Let's say out of 10 individuals who are at risk for getting your smallpox, if you administered the variola or the smallpox vaccine, let's say to 8 individuals, 2 people will not be vaccinated. However, because the 8 have been vaccinated already, there will be little possibility for the virus to be passed on from one person to the next, to the point that even the two people who were not previously vaccinated would get protection because the other eight have been vaccinated already. That is how we were able to eliminate or eradicate rather your variola. Variola is only known to have a single reservoir, and that will be your humans. Since many of us or many of our ancestors have been vaccinated against variola, there came a time that even for us, the younger generation, there was no need for the variola vaccination anymore because it has been eradicated. So, this is an example of an infectious process wherein it's exclusively seen to have your human reservoir. Then you will have your animal reservoir. This is often seen in patients with zoonotic infections. As the name implies, zoonotic infections normally come from exposure to animals that harbor a particular etiologic agent. This is what we call your cutaneous anthrax. Now, where do we get the bacterium Bacillus anthracis? It is often seen among cattle. So the cattle is our cows will be the animal reservoir for your Bacillus anthracis. Both your variola and your anthrax are considered weapons for bioterrorism. When I was doing my fellowship training, my master's rather, my master's training in tropical medicine, I had the opportunity to have an exposure, an area of a 2 week wet laboratory exposure at the Armed Forces Research Institute for Medical Sciences in Bangkok, Thailand. So this is the military, the military laboratory of the armed forces of the US with the other Southeast Asian countries. And some of our colleagues in Bangkok were sharing anecdotes that basically your anthrax and your smallpox allegedly are harbored in military camps, both in the US and in Russia, because these are now being used as potential weapons for bioterrorism. So, again, just highlighting here how it could be of public health importance when you, let's say, accidentally release anthrax or smallpox to the population. It could result in mortality if you're not able to control these infections. Then you have your Legionella pneumophila, and your Legionella pneumophila is known to be the causative agent for your Legionnaire's disease. Basically, this flagellated bacterium was first identified to thrive in the filter mechanism of air conditioning units in one of the conference halls in the US when the Legionnaires had a meeting. So after attending the meeting, all of the participants started to develop severe pneumonia-like symptoms, and eventually the epidemiologists and clinicians were able to identify this bacterium, your Legionella pneumophila, in the wet or in the damp aircon filter of the air conditioning units of the convention hall. So this exemplifies an environmental reservoir. When I say environmental reservoir, these are often non-living, um, non-living things that would be a good culture medium for the growth and propagation of your etiologic agents. However, be mindful that not all communicable diseases have reservoirs. For example, there are those that are transmitted directly without intermediaries. This would include some of your more commonly encountered sexually transmitted infections, respiratory pathogens, measles, mumps, and even your streptococcal infections of the respiratory tract. So I mentioned this earlier on the zoonotic infections. This would often result in transmission from when you acquire the pathogen from an animal. So your Bacillus anthracis, the one that causes your anthrax, This bacterium is known to have several type of active bacterial. Then you have the dormant or the non-active spores. So again, this is something that might be of interest to you when you go to microbiology or parasitology in sophomore year. We now go to your portal of exit. Basically, when we talk of of exit, how does the bacterium or how does the infectious agent leave one sick individual so that it could be passed on to its next susceptible host? Normally, there is a concept of what we call tropism. When we say tropism, your etiologic agents would have preference for certain organs or tissues in the body. For example, when we talk of your Mycobacterium tuberculosis, the tropism for your Mycobacterium tuberculosis would often be in the apical regions of the lungs where there is very good oxygenation. So it's in the lungs, it's your pulmonary cause. That's why when we talk of pulmonary tuberculosis, this is transmitted when you cough out, when you do not properly do cough etiquette. When you cough, you don't cover your mouth, you transmit the infection every time you open your mouth because there is tropism of the mycobacterium for the lungs. It is through coughing that the portal of exit becomes part of the chain of infection. Or let's say in the case of typhoid Mary, because her Salmonella typhi would often produce gastrointestinal symptoms, it is often transmitted by the fecal oral route. If you defecate, if you check the fecal material, you might find this bacterium in the tissue specimen. So portal of exit. Now we go to the next link, which is your mode of transmission. When we talk of modes of transmission of communicable diseases, we can dichotomize them in general into two. You have your direct and your indirect. Under indirect, this is where our topic for today becomes relevant. You have your vehicle-borne and you have your vector-borne infections. When I say vector-borne infections, I am pertaining to um invertebrates that have the capacity to transmit an infectious agent. In contrast, vehicles are non-living things. For example, we can talk of food, water, or fomites, let's say your blanket or your clothing. These are all types of vehicles. Your vector-borne will be further divided into your mechanical vectors and your biological vectors. I will discuss these two in finer detail in a short while. But in general, when we talk of biological vectors, the arthropods or the vectors or the noxious invertebrates involved with this would require active involvement in the life cycle of the infectious agent. Unlike your mechanical vectors, they are merely transmitted through, let's say, contamination or exposure. Now, direct exposure. Now, for indirect contact, we also have your airborne, and then you have your direct, which would have your direct contact, let's say, or your droplet spread. So you might ask, what is the difference between droplet spread and airborne? In your airborne infections, they often involve your droplet nuclei. So what makes your droplet nuclei different from your droplet spread? Droplet spread happens via direct transmission, while your droplet nuclei would refer to your indirect transmission. Examples of your airborne or droplet nuclei infection would include your measles and your tuberculosis. On the other hand, your pertussis and your meningococcemia would fall under the droplet spread. The main difference between the two will be the size of the particle. Droplet nuclei are basically smaller molecules that remain suspended in the air. Unlike your droplet spread, they often have bigger particles. That that often, because of the sheer pull of gravity, often would fall to the ground. Let's go back to 2020. If you will recall, when we first encountered your COVID-19 back in 2020, we call this your novel coronavirus of 2019, or your nCoV 19. When we first heard of nCoV 19, what were some of the instructions of the epidemiologists and the public health experts? We were wearing face shields. We were taught to have physical distancing. When I say physical distancing, you have to be about 6 feet away from someone. Why? If it's a droplet type of spread, the droplets are very big. So let's say if you cough out the droplets, because they're very big, they can only travel a short distance. So if I cough out, if it's droplet spread, it will only go to a certain distance, not greater than 6 feet or 6 feet in distance. Hence, when we first heard of nCoV 19, we were told wear the face shield, keep the physical distancing, because we know that your coronavirus was spread via droplets. Now, let's talk about droplet nuclei. These are smaller droplets that remain suspended in the air. For example, I have tuberculosis. I enter room A. While I am staying in room A, I suddenly cough. Because the droplet nuclei are very small, they remain suspended in the air. Then I, the person who has the TB or the tuberculosis, would leave the room. Then after I leave the room, a second person enters that room. And because the droplet nuclei remain suspended in the air, that second person, even though we did not have direct physical contact, that person can still develop the infection and acquire tuberculosis. If you have the opportunity to visit TB directly observed treatment short course facilities or TB DOTS centers in your barangay health centers, you would notice that most of the clinics would have exhaust fans, or they would have electric fans that blow off the air going outside of the window or outside of the door. That is because they want the suspended nuclei, droplet nuclei, to be transmitted to other parts, not just limited within the room. That's the difference between your droplet nuclei and your droplet spread. So again, for academic purposes, the topic for this session will focus on your vehicle-borne and your vector-borne. Vehicle-borne would include your food-borne infections and your waterborne diseases. But again, because I opted to talk about prevention and control of communicable diseases in general, I also want you to be aware of this concept. So I mentioned this when I say direct contact. There could be skin-to-skin contact, kissing via sexual intercourse, or in the case, let's say, of your schistosomiasis, let's say the infected stage of the schistosome is released from the cow or the carabao, and let's say it defecates in ponds, and in the ponds, this is where the second the vector would now be exposed, no? And when we talk of your schistosomiasis, this is a mollusk. This is your Oncomelania quadracei. It is a snail, and eventually the snail will acquire the juvenile form of the schistosome, and this can actually result in direct penetration of the skin of a person who is wading in the pond. So, again, just to highlight examples of your direct contact transmission. I've mentioned about indirect transmission when we are looking into airborne droplet nuclei or the use of inanimate objects or your animal vectors. Then the portal of entry would refer to the manner in which a pathogen would enter a susceptible host. The portal of entry must provide access to tissues in which the pathogen can multiply or a toxin can act, and oftentimes infectious agents use the same portal to enter a new host that they use to exit the source host. Other portals of entry would include the skin, the mucous membranes, and the blood. Now we talked of the next susceptible host. This is a potentially sick person. Now, when we talk of susceptibility to communicable diseases, it would entail knowledge on the genetic and constitutional factors, distinctive immunity, nonspecific factors, or even genetic makeup. What do we mean by this? There are certain physiologic changes in a human body that can confer protection to certain conditions. For example, when we talk of sickle cell anemia, for the medical technologists in the group, you might be aware of the normal morphology of your red blood corpuscles. They're usually biconcave red discs, but with sickle cell anemia, this biconcave disc appearance or morphology becomes different. They become sickle cell in shape. And because of this abnormality, let's say the plasmodium, which is the causative agent for malaria, the plasmodium species cannot utilize these abnormally shaped red blood cells. So the life cycle of the plasmodium ends. And because of this, getting sickle cell anemia confers some form of protection against malaria. But of course, it can lead to other bleeding dyscrasia and other related pathology. But the bottom line is what we're referring to here is how genetic susceptibility or distinctive immune patterns would dictate on how a person or a susceptible host will respond or cope with the communicable agent or communicable disease. So, from a public health perspective, we have gone through the different links of infection: the agent, the reservoir, the portal of exit, the mode of transmission, the portal of entry, and susceptible new host. Any public health intervention to control and prevent or curb the burden of your infectious diseases would entail knowledge of initiating or implementing preventive strategies, breaking the links of the chain of infection. So let's go back to vehicle-borne diseases. Again, when I talk of vehicles, they may indirectly transmit an infectious agent, and this would include food, water, biologic products, or even your fomites. A vehicle may passively carry a pathogen, and alternatively, the vehicle may provide an environment in which the agent can grow, multiply, or produce the toxins that would cause the infection. In contrast, vectors are often invertebrates that are a bit noxious or a bit parasitic in nature. When we talk of your vectors, this would include your mosquitoes, your fleas, your ticks, and they could be referred to as either mechanical vectors or your biological vectors. If for those of you with units on entomology, or those, let's say, biology majors or zoology majors who have studied, let's say, your fly. A fly has hairy appendages on the on its extremities. Let's say, for example, a fly lands on horse dung or cow dung or dog fecal material. They normally land on the fecal material, and then suddenly, after touching the fecal material, some of the fecal material can stick on the hairy legs of this particular fly. And then the fly now moves to another object and lands on your food. So if this fly initially landed on fecal material, the fecal material is now inadvertently passed on to your food. And if you ingest the food, it can also get your salmonella. That is an example of a mechanical vector. In contrast, when the vector is an integral element in the completion of the life cycle of the pathogen. That is what we refer to as your biological vector. So, moving on, let's now discuss food-borne or vehicle-borne diseases. So, why is it important that we are aware of the burden of food-borne diseases? Because basically they are of public health concern because they still contribute to the global burden of disease and mortality. There are about 200 diseases that have been linked to contaminated food. When I say contaminated food, I am referring to those that have been tainted with bacterial species, virus, parasites, or even chemical substances such as your heavy metals. Now, foodborne diseases are caused by contamination of the food and occur at any stage of the food production, delivery, and consumption chain. They can result from several forms of environmental contamination, including pollution in water, soil, or air, as well as unsafe food storage and processing. Now, foodborne diseases encompass a wide range of illnesses from your typical acute gastroenteritis or your diarrhea, even to your malignant neoplasms. Most present as gastrointestinal issues, though they can also produce neurological, gynecological, and immunological symptoms. Now, the thing with your foodborne diseases, they are more commonly encountered in low income and middle income countries. And sadly, it is the pediatric population which is most susceptible to complications related to your diarrhea or your acute gastroenteritis, in particular, children less than 5 years of age. I want you to recall a particular bacterium. So when we sorry, let me before I go into that. When we talk of foodborne illnesses, I often they are secondary to diarrhea. And the diarrhea is often because of a virus, your norovirus, or to a certain degree, a bacterium or Campylobacter. Now, latest data on US biostatistics, they said that your non-typhoidal Salmonella enterica is the most notorious for foodborne diseases that can lead to diarrhea and invasive diseases. But be mindful that there are other causative agents or etiologic agents for your foodborne conditions. This will include your salmonella, your tenia, or your pork tapeworm, your hepatitis, and from your mushrooms or aflatoxins. Now, whenever we talk of foodborne diseases, it is also imperative that we talk about food hygiene, food safety, and food sanitation. These are similar but not exactly synonymous concepts from a public health perspective that address foodborne infections. Food hygiene is different from food safety and food sanitation. For academic purposes, I will leave this for your perusal. Now, whether we're talking of food hygiene, food safety, or food sanitation, the common denominator is we want food that is fit for human consumption, and we do not want to introduce any harm or disease while ensuring that the food that we consume would provide the needed nutritional function. We talk of food contamination as those that can spoil or taint the food. There are many possible food contaminants, microorganisms, toxic substances, or we can divide them into three categories: your biological, your chemical, or your physical contaminants. Now, food contamination may occur at one or several routes throughout the supply chain. I want you to read on the concept of from farm to fork. There have been a lot of studies on this. Basically, what they're trying to say is you want to ensure that directly from the farmers, you can avoid the middlemen, and then you can sell directly your produce to, let's say, other consumers, and anything in excess you can consume as your own food. And this is what the concept of from farm to fork is all about. Now, why do we give importance to food contamination? Because, again, at the end of the day, we do not want food that is unfit for human consumption. So when we talk of food contaminants, we can have biological hazards. For academic purposes, I will just let you read on these. But when we talk of biological hazards, they could be bacterial species, and these are some of the more commonly encountered agents. Your viral species, again, some of their more common clinical manifestations. I want to emphasize here your hepatitis A is a special type of communicable disease. Hepatitis A, in its strictest sense, is considered fecal-oral route of transmission. When I was in medical school, which was not so long ago, we only had six types of hepatitis A, B, C, D, E, then G. Now we have different types of hepatitis, including your hepatitis non-A, non-B. So why is this of special concern? In 2010 or 2015 onwards, the US Centers for Disease Prevention and Control reclassified your hepatitis B as a purely food-borne infection to now a sexually transmitted infection. In particular, this is true for men who have sex with other men who engage in sexual activities that include fellatio, which is basically oral sex, and insertive and receptive anal sex, including sodomy. If you perform anal and oral sex simultaneously on a person, there is now the completion of what we refer to as the fecal-oral route. If, let's say, you perform insertive anal sex, and then after that, fellatio or oral sex is committed, then you complete the fecal oral route. That is why, in particular, the US Centers for Disease Prevention and Control categorically said that among the MSM, your hepatitis A is also classified as sexually transmitted. Parasites would include your worms, your trematodes, and of course, the more common one would be your tapeworms, and other parasites such as your Ascaris lumbricoides. Your Ascaris lumbricoides will fall under your soil-transmitted helminths or your helminthiasis. This is one of the priority neglected tropical diseases that the World Health Organization as well as the Department of Health are closely monitoring. Then you have your prions. As I've said earlier on, your prions are proteinaceous material, very similar to your viruses, but they are notorious for causing what we refer to as your spongiform encephalopathies, as exemplified by the mad cow disease, or what we refer to as your Creutzfeldt-Jakob disease, which is also one of the notifiable diseases that we have here in the Philippines based on the Philippine Integrated Surveillance PIDSR, Philippine Integrated Disease Surveillance and Response System. Now, your prions are known to be transmitted if you consume infected brain tissue. Why is this something of public health relevance? Back in circa 1960s and 70s, in Papua New Guinea, a certain tribe was practicing cannibalism. In that tribe of Aborigines in Papua New Guinea, if a chieftain dies, what the tribe does is they open up the brain of the dead chieftain, and then they literally get the brain material and they feed the brain to the younger members of their tribe, with the belief that the knowledge of the dead chieftain is passed on to the next generation. But because of this cannibalism, and children were getting infected with the prions, they developed mad cow disease, or something similar to your mad cow, but instead of eating cow, they're eating humans. And this is what resulted in what we refer to as your kuru, 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 which is very similar to your Creutzfeldt-Jakob disease. So again, this is because of cannibalism among the tribal aborigines of Papua New Guinea. Then you also have your chemical hazards. Basically, these could be your pesticides, heavy metals, and other chemicals. For academic purposes, I just want you to note that there could be also naturally occurring toxins that can result in several clinical manifestations. And they can also impede the immune system of an individual, resulting in a myriad of medical conditions. Perhaps the most notorious of this would be your Clostridium. Your Clostridium is it's a bacterium. It's an obligate anaerobic bacterium, meaning to say they are more they thrive more in an environment with very low oxygen level. If you've seen old canned goods that are already ballooning, there is a big possibility, especially if this is meat, there is a big possibility that this contains this bacterium, your Clostridium botulinum. Your Clostridium botulinum exists in the dormant spores and the active adult forms of the bacterium. And if you ingest this preformed toxin from your Clostridium botulism, it can result in degenerative symptoms. So that will be similar even to your myasthenia gravis. So this is something that we don't want to happen if you consume chemical toxins from your Clostridium botulinum. There is also what we call your Clostridium perfringens from the same genus but of different species. This is a you get the toxin if you consume uncooked poultry products rather. Then the next type would be your Clostridium difficile. In among Filipinos, we call it Clostridium difficile. Among Americans, they say Clostridium difficile. This is the most common nosocomial infection that you acquire if you touch a sick person's excreta, let's say in the hospital, and you did not properly use hand hygiene or you didn't wear personal protective equipment or gear, you can acquire toxins from your Clostridium difficile that can lead to very severe types of diarrhea. So again, just to highlight other types of chemical hazards, for academic purposes, I will leave this as reading materials for you guys. Then you have your physical hazards. This will include any foreign body that could contaminate the food. At the peak of the COVID-19 pandemic, I'm not sure if you recall, but there was an incident that went viral wherein Jollibee in BGC accidentally served the towel that was wrapped in the batter of your chicken joy. And when the customer was eating it, of course, he discovered that instead of chicken, it was a piece of hand towel. And this is a perfect example of your physical hazard that could contaminate your food. I also want you to know the difference between your food-borne infection and food poisoning. There are a lot of similarities between these two, but there are also subtle differences. For academic purposes, I want you to go through both the definition and the characteristics that would differentiate your food-borne infection from food poisoning or food intoxication. Now we move to food safety. The World Health Organization, together with the US Centers for Disease Prevention and Control, advocate for food safety, meaning to say you want to have access to sufficient, safe, and nutritious food, not only for sustaining life, but also for promoting good health. Now, we talk of foodborne related infections and we look at the global burden if we are not properly advocating for food safety. Now, sadly, when we talk of foodborne diseases, who suffer the most would be those belong in the extremes of ages. In the Philippines, as well as in other developing countries, children less than 5 years of age carry 40% of the overall burden of your foodborne diseases. And the most common would be your diarrhea or your acute gastroenteritis, affecting about 550 million sick people, resulting in about 230 deaths on an annual basis. When it comes to food safety, nutrition, and food security, these are concepts that are properly linked together. Unsafe food creates a vicious cycle of disease and malnutrition, again, especially among those in the extremes of age, the young pediatric population, and the geriatric age group, as well as those who are immunocompromised. From a public health perspective, foodborne diseases also impede socioeconomic development because it can inadvertently affect or indirectly impact on the national economy. So just to give more data on food safety. Now, we also want to come up with food that will be safe for general consumption. And so the World Health Organization has advocated ways on how people will have access to safer food. We have developed ways of food preservation. It could be through heating or the use of acids and other natural antimicrobials or even your non-thermal processes. For academic purposes, I want you to read on these types of food preservation. In the same manner, the WHO advocated for five keys to safer food. They want the environment to be kept clean. They want to teach people who prepare the food to always separate your raw and cooked food. If you are fond of eating samgyup, I remember when the first time I visited Seoul and Busan, as well as Daegu, of course we were craving for Korean barbecue. One of the things that we first learned among the Koreans is that they have to separate the raw food from the cooked food. So when you do the samgyup, normally we prefer you use different tongs, different scissors if you are picking up the raw versus the cooked food. So you separate them using different plates or what have you. You want to cook your food thoroughly to ensure that there would be pathogens that die at a particular temperature. So we want to achieve that to ensure that we're killing all potentially dangerous pathogens. And just so you know, there is what we refer to as your temperature danger zone. It is in this range of temperature, somewhere between 5 to 60 degrees Celsius, that your bacteria would be more active, or they would thrive or grow quickly. So when we talk of food safety, we want to store food either in the hot zone or in the cold zone because that would ensure food safety. And of course, you use safe water in raw materials. This is very true when we talk of the different types of water related disorders. At this point, I also want you to do supplemental reading. What differentiates your waterborne from your water washed, from your water related or vector related, and your uh, vector-borne, water-based, waterborne, water-related, and water-washed types of communicable diseases. So we will go through that perhaps some other time, but I want you to do supplemental reading on those as well. Now, from a public health perspective, we have Food Safety Act of 2013. This is Republic Act 10611, which was enacted during the term of the late President Benigno S. Aquino III. And basically, what does this law tell us? Again, I want you to do supplemental reading on this. It will be impossible for me to give the highlights of the law, but basically, it talks about what measures the government will implement in terms of ensuring that the food that consumers have access to will be safe for general consumption. Again, I will let you read on this. This is part of your reading assignment. Moving forward, we go to your vector-borne and vermin-borne diseases. So, vectors and vermins. Again, vectors are basically smaller or living organisms that transmit infectious pathogens between humans or from animals to humans. Now, many of these vectors are involve your blood-sucking insects. So your class among the medical arthropods, your insects together with your crustaceans and your arachnids are the ones that are more commonly notorious for causing your vector-borne diseases. But of course, you can also have other invertebrates such as um, your mollusks or your snails. Often, once a vector becomes infectious, they are capable of transmitting the pathogen for the rest of their life during each subsequent bite or blood meal. When we talk of vermin, these are noxious, objectionable, disgusting animals that are generally small, and they are very quite difficult to control in terms of population reproduction. So these would include your lice, your bed bugs, your flies, your roaches, and of course your mice and your rats. When we talk of your vector-borne diseases, they would often be caused by parasites, viruses, and bacteria that are transmitted by vectors. From a public health perspective, some of the more commonly encountered communicable diseases, not only in the Philippines but in other tropical countries, would be your vector-borne infections. In our country, in particular, of those of priority concern would be your malaria, your dengue, your Japanese encephalitis is slowly becoming more and more common, and as well as your schistosomiasis and your lymphatic filariasis, which are both considered neglected tropical diseases. Now, they are often referred to as neglected tropical diseases because there is highest incidence in tropical and subtropical areas, and of course, they disproportionately affect the poorest populations. We refer to your neglected tropical diseases as most of them being vector-borne for a variety of reasons. So again, just to highlight what are those that are of public health relevance in our country, it would include your Zika and your lymphatic filariasis because they cause chronic suffering, lifelong morbidity and disability, and of course, sometimes they get stigmatization. And the problem with your vector-borne diseases, global travel and trade, and of course, our urbanization can impact or can contribute to the public health burden of such vector-borne diseases. So this is your Zika. This is an infectious process transmitted by the Aedes mosquito. Basically, what happens is that for children, in fact, for mothers who give birth to children with Zika infection, it causes the premature closure of the anterior fontanelles of a baby because the fontanelles o yung bunbunan ng baby nag-close ng maaga, there would now be inability for the brain to develop normally. And so there would be subsequent mental retardation among patients with microcephaly, which is often associated with the Zika infection. If you Google this or if you look into YouTube videos, you might see children who look like chimps or monkeys because the anterior fontanelle closed on early. They did not develop the brains did not develop effectively, and these children suffer from mental retardation. Some of them are not even cannot produce verbal output. Another vector-borne disease would be your lymphatic filariasis. This is an example of your hydrocele wherein there is obstruction of the lymphatic drainage that can produce significant enlargement and grotesque deformation of the scrotal area. And this is something that is can only be corrected through surgery. And again, people who get infected with your lymphatic filariasis are those who live below poverty line, and so they become neglected. So I'll also give a brief rundown of these. These are your invertebrates of medical importance. I have focused on your family Arthropoda, and under your Arthropoda you have your class Insecta, class Arachnida, class Crustacea, among those that would often transmit infections or cause human problems. You will encounter all of these when you go to sophomore year under parasitology, but I'm just giving you a glimpse or an overview of the invertebrates of medical importance, because aside from causing vector-borne infections, they can also result in direct injuries in humans, including envenomation, ectoparasitism, hypersensitivity or allergic reactions, myiasis, and even some type of psychogenic conditions such as your entomophobia or your delusory parasitism. Briefly running through them, when we talk of envenomation, under your hymenopterans, these are your bees, wasps, yellow jackets, and your fire ants. These are insects that are notorious in causing envenomation that can precipitate even untimely demise of patient if you get anaphylactic shock. Then, of course, some of your centipedes and your millipedes, they can also cause allergic reaction. And among the arachnids, your spiders and your scorpions can also envenomate and cause um, ill health to humans. In terms of ectoparasitism, you can also have, this is an example of this is your African sleeping sickness. This is caused by the Redoviid bug. It can cause a lot of nervous system manifestation. I will ask you to read on this, and when you go to second year, when you go to pathology and parasitology, you will encounter again your African sleeping sickness. Or sometimes these are your lice and your crabs, no? Yung mga pubic lice, no? These are some of the ectoparasites that you might encounter. And of course, sometimes if you're exposed to the powdery wings of your wasps and your butterflies, these can precipitate allergic reactions, and so they can also cause injuries to humans. I love watching extraction of botfly larvae in YouTube. So this is exactly what trichomoniasis is all about. So I'll encourage you to check on these videos. These are examples of your myiasis involving your maggots. Entomophobia would, some of them would have unfounded fear or hallucinations related to insects and other or arthropods in general. So, from a public health perspective, you also need to know the mosquitoes that are of public health relevance. Now, there are three genera of mosquitoes that cause human infections. The more popular would be your Anopheles, your Aedes, and your Culex. When I was doing my master's in tropical medicine, when we went to AFRIMS, I had the opportunity to go into their mosquito laboratory. We had to dissect mosquitoes and we had to study the life cycle. I had to study the different morphologies of the larvae, the eggs, or even the way they feed. There would be mosquitoes that feed with their legs up, those that are on the horizontal leveling. So these are just some of the different morphological characteristics of the various genera of mosquito vectors. For academic purposes, I want you to read them. In your review notes and manuals. We included several articles also on the different types of mosquitoes that can transmit arboviruses or arthropod-borne infections among humans. Among the arboviruses, the most notorious, especially in the Philippines, would be your dengue. Back in the 1960s, when dengue was first described, I'm not sure if you are aware, but in older literature, dengue was first referred to as the Philippine hemorrhagic fever because it was first described in detail in the Philippines. So this is a public health burden. And if you look at our country, we are experiencing dengue as early as 1950s, and over the years, we have seen dengue multiply and increase in number. When I was in medical school, we were taught that dengue was a seasonal type of infection. But you need to understand that during my medical school years, we didn't have much impact yet of climate change. So back in the day, we literally had the dry season and the wet season. The wet season would often be sometime from May to September. And during that time, this period, this is where the highest cases of your dengue would be more apparent. But because of climate change, we are now seeing storms, tropical depressions entering the country as early as January until December. And the Pag-asa says that in a year, the Philippines records about 28 tropical depressions on an annual basis. And because of that shift in the climate change, we're now seeing dengue as a perennial problem in the Philippines, not just seasonal. Now, latest data on the World Health Organization has identified that the Western Pacific region continues to have the high burden of your arboviruses or your mosquito-borne arthropod infections. In our country, as of February this year, Quezon City remains to be problematic when it comes to dengue outbreak. And many interventions have been done to control or address the burden of dengue in the country. One of these would be the use of mosquito repellents, or sometimes we tell our patients to wear long sleeve shirts. Often we tell them to wear light colored versus dark colored garments because your Aedes mosquito is characteristically a day biting mosquito that often is attracted to light colored garments. This is in contrast to your Anopheles mosquito, which is the night biting agent or vector for your malaria. And there are certain subtle differences with the behavior, the vector biology of your Aedes and your Anopheles. And so, even the way we think of your preventive measures, even though they're both mosquito borne infections, the strategies are slightly different. Now, we also want to identify the public health burden of dengue. And so in 1993, the government started to have the National Dengue Prevention and Control Program, which entailed vector surveillance, early diagnosis, prompt treatment, integrated vector management, outbreak response, health promotion and advocacy, as well as research. Now, from a public health perspective, one of the initiatives of the DOH or the Department of Health is the 4 o'clock habit. Basically, it encourages everyone in a community with high dengue burden to start cleaning their backyards, their gardens, and removing all potential breeding grounds for your mosquito vector. So, among those living below poverty line, among the marginalized or those informal settlers where they use old tires on top of their roofs as added weight to protect them from the typhoon. So that could be a breeding ground for your mosquito. So every 4 o'clock, everyone in the barangay would be encouraged to start cleaning as part of the cleanup measures to address dengue. And then recently, the 4S has been modified into your 5S strategy of the Department of Health. The 5S would stand for search and destroy, mosquito breeding sites. It would also entail the use of self-protective equipment, wearing long sleeves, early consultation if you develop the symptoms. For those with dengue outbreaks, the judicious fogging is also supported. And of course, we want to ensure that dengue, just like any other viral infection, is generally self-limiting. So we provide antipyretic agents for fever. We ensure that the patient is properly hydrated to minimize the sequelae of your dengue. So this is now the modern or the revised 5S, which was previously referred to as the 4S contra dengue. Then, of course, as much as we want to control dengue, we're not achieving the targets. I want you to read on this what are some of the struggles that the Department of Health has been dealing with in terms of the National Dengue Prevention and Control Program. Now, the most obvious problem is the lack of a vaccine. Unfortunately for the Philippines, in 2016, Dengvaxia was introduced. However, due to controversies brought about by unfounded claims by the public attorney's office, there was a lot of controversies implicating the Dengvaxia as something that is not beneficial, when in fact, from 2015 onwards, Dengvaxia remains to be in use to be in use in other parts of the globe. So contrary to the claim or the unfounded allegations of the public attorney's office, there was really no link for your Dengvaxia to the alleged premature demise of children. But I will have to say that there was a problem with the execution of the vaccine rollout. Dengvaxia is intended to be given for patients who previously had dengue, not for patients who had never been exposed to dengue. That is where the problem came about when DepEd gave a mandatory vaccination of children, even for those patients, even for the children who were not who never had dengue in their entire lives. So that is where the problem lies. Now, to date, uh, Dengvaxia is slowly being removed from the market, not because it is unsafe, not because it is not effective, but there are now newer molecules or newer vaccines that are being introduced or being investigated as an alternative to your Dengvaxia. One of which will be your Qdenga. I'm not sure if this will be available in the Philippines soon, but just so you know, as of April 2025, this is the one that is now being advocated by the World Health Organization. We now go to malaria, which is another vector-borne infection that is of prevalence in the country, high prevalence in the country. This is caused by a parasite or Plasmodium. And again, this is a tropical type of infection that is preventable and curable. There are different types of malarial species. Your Plasmodium falciparum, Vivax ovale, malariae, and your knowlesi. Now, again, looking at the public health burden of malaria, it affects primarily, especially in terms of mortality, people who are on the extremes of ages, especially children below 5 years of age. Now, there are many differences with the way we look into the preventive and control measure for your malaria. So when we talk of malaria, the more dreaded types would be your falciparum and your vivax. But again, just wanted to highlight that there are other species, including your ovale, your malariae, and of course, the most recent identified plasmodium would be your knowlesi. I also want you to think of other vectors that can transmit infections in human. I've mentioned earlier on your Reduviid bug for your Chagas disease. Then you also have your Cheche fly that causes your African sleeping sickness. This is an image of your sandfly, which causes your leishmaniasis. If you are able to, let's say, in the future, for example, you join Doctors Without Borders, you might encounter these common vector-borne infections in Africa, in sub-Saharan Africa. I've also talked about mollusks as another type of vector. So these are no longer insects, but they are different types of vectors. They are still invertebrates. The more commonly encountered snail-related infection would be your schistosomiasis. So for academic purposes, I want you to read on these, but just be advised that there are a variety of snail-transmitted infections in the Philippines. The more commonly encountered would be your blood flukes. This would include your Schistosoma japonicum, your Schistosoma hematobium, and your Schistosoma mansoni. For academic purposes, I will not be able to discuss all of these in details with you. I want you to do supplemental readings on these snail-transmitted infections. So I've mentioned about the NTDs and the vector-borne diseases. They are considered neglected. Neglected why? Because again, first, they are often commonly encountered in people living below poverty line. Because these people are financially challenged, there is inability for them to acquire resources that would address the infection. Neglected because there is not much robust epidemiological data or no research done on these conditions. And the reason behind that, most researches are being conducted by developed countries or that are usually temperate regions. And your NTDs often are seen in tropical developing countries. And so when the funding is not prioritized by the temperate regions, it becomes neglected. Just to share with you, in 2024, Dr. Wanko, and myself, we were supposed to do a study on lymphatic filariasis in Mindanao, and the proposal was already approved by the World Health Organization. But then that this was sometime in quarter three or quarter four of 2024. But come 2025, Trump happened, and Donald Trump withdrew the US from the WHO. And so all research studies that were being funded by the US had to be terminated, including that particular study on lymphatic filariasis in the Mindanao region. That is an example of why neglected tropical diseases continue to be problematic in tropical countries because we don't have the resources to do exhaustive research to address the public health burden. So, for academic purposes, these are the priority NTDs of the World Health Organization and the US Centers for Disease Prevention and Control. This would include your lymphatic filariasis, which we have in the Philippines, your onchocerciasis, your schistosomiasis, which we also have in the Philippines, your soil-transmitted helminthiasis or your ascariasis, we do have that, or even your trachoma, we do have that, and of course your your guinea worm disease or your dracunoliasis, which is also the priority concern of the CDC and the WHO. So four of the six priority NTDs are also seen here in our country. Moving forward, we now go to your vermin. Vermins would include predominantly your rodents, rats, and mice. Now, these diseases can be spread to humans directly through handling of rodents or through contact with rodent feces, urine, or saliva, or even through rodent bites. Diseases carried by rodents can also be spread to humans indirectly through ticks, mites, or fleas that have fed on an infected rodent. So, just so you know, in the country, we do have several rodents that live closely to humans. You have your Ratus ratus, you have your Ratus turvigicus. These are your sewer rats. Then your typical house mouse or your mus musculus. But look at this. Sometime in 2022, a new species of mouse was discovered in Davao. So imagine all of the potential illnesses that could be transmitted by these rodents. Now, the primary strategy for preventing human exposure to rodent diseases is effective rodent control in and around the home. And this is often achieved by eliminating any food sources for the rodents, sealing even the smallest entries into homes, and successfully trapping rodents in and around the home. Now, some of the characteristics of your rodents are as follows. Notice that your Norwegian rat or your Norway rat can swim, and they are actually good swimmers. So even if flooding occurs, these nasty vermin can still escape the flood. And of course, you don't want to talk about flood in the concept of flood control projects, which is also plaguing our country to this day. But of course, just to highlight, these are some of the more commonly encountered diseases that are transmitted by the rodents. Of these, the most popular of which will be your leptospirosis. And if your leptospirosis develops the hepatorenal complications, it can now become your Wales syndrome. So, how do we control the rat population or the vermin population? These are some of the general measures that we can think of how to control the rats. So, we want to eliminate the rats from entering our homes, or we don't want to give the rats an opportunity to cohabitate with us, or we can destroy the rats. We can do trapping. We also use some predators, for example, your cats and terriers. We can gas them using calcium cyanide. We can poison bait them using single dose acute rodenticides or your multiple doses. When I was a biology major in UP Diliman, I remember one of our tasks in biology 160, if I remember correctly, in ecology, we would go to the sunken garden as well as into the lagoon, and we would set up these mammal traps, and we would collect rodents. Imagine, I am so afraid of rodents. I'm afraid of sewer rats. I can handle mice, but not sewer rats. And I remember when I was a resident in PGH at the Philippine General Hospital, we had the roborats. They were massive rats, bigger than puppies and cats, and they were not afraid of humans. Whenever you would cross, let's say, and they would normally be frequenting the mess hall at the Philippine General Hospital. For those of you who graduated from UP Manila, if you're aware of PGH, in near Ward 15A and Ward 16, the trauma wards, if I remember correctly, and Ward 5, near the mess hall, the rats were all over the area and they were so scary for me. And of course, we do know that they can cause a lot of human infections, but we have to live with them, especially how do you control it if they are literally coming from the sewers, from Taft Avenue, and from all parts of Manila. So, again, just to highlight the burden of your controlling your rodents. We use two types of rodenticides as part of the control measures to address the population of your rodents. So for academic purposes, I want you to know the differences between your barium carbonate and your zinc phosphide. So I've talked about leptospirosis. This is something that is commonly encountered during rainy season when people have to wade in flood water. And of course, we also want to protect humans from possible leptospirosis. And so most of us would be hearing a lot of health promotive um, activities that would bar us from getting leptospirosis. We're having a lot of issues with the flood control programs, not only in Metro Manila, but in other parts of the Philippines. And so every time there would be flooding and people are forced to wade in flood water, they don't have the luxury to travel in their Rolls Royce with their expensive umbrellas. So, how do we protect people from possible contamination or exposure to leptospirosis? Leptospirosis can be potentially fatal, especially once you develop the overt symptoms of leptospirosis. In its natural history of disease, you have your anicteric and your icteric phase of your leptospirosis. From a public health perspective, the Department of Health is advocating for post exposure prophylaxis. We classify exposure to flood water as potential exposure to leptospirosis, and we classify the risk as this low risk, moderate risk, or high risk. And depending on the risk stratification or risk categorization, there are different prophylactic regimens that are being recommended to prevent onset of your leptospirosis. This would involve primary level of protection against your leptospirosis. In the same manner, when we talk of vector problems, we have what we refer to as the global vector control response. And this has been ongoing for several years, and there are targets until the year 2030. I want you to do supplemental readings on this. I am just giving you an overview of what the global response is when it comes to vector control. And ultimately, what we do want is a collective effort on all sectors to address the global burden of vector-borne infections. And we relate this to what we refer to as United Nations Sustainable Development Goals. I'm not sure if you've heard of the 2010 to the 2015 UN Millennium Development Goals. Uh, for those of you with background on public health, you might have heard of the Alma Ata Declaration of 1978, wherein we were trying to achieve health for all by the year 2000. Unfortunately, when 2000 came, that battle cry of health for all by the year 2000 was not properly achieved. And so the health experts and world leaders reconvened and they identified the 2010 United Nations Millennium Development Goals that had a 5 year span of addressing some of the global targets. One of the global targets there is addressing the big three for communicable diseases. What are the big three for your communicable diseases? The first would be your HIV/AIDS, then malaria, which is a vector-borne infection, and then your pulmonary tuberculosis. When we failed to achieve all the UN Millennium Development Goals in 2015, the United Nations reclassified and reaffirmed that primary health care was the strategy to be employed to achieve universal health coverage, and this was now converted to United Nations Sustainable Development Goals with the ultimate aim of achieving health for all by the year 2030. Now, the global vector control response is also tied up to the UN Sustainable Development Goals. And some of the strategies from a public health perspective being advocated by the global vector control response would include the following: behavioral change, health education, increase in public health awareness, access to water and sanitation, and of course, water sanitation. So they are all related to environmental control, addressing problems with climate change as well. Now, I want to highlight that we have talked about all of these already, but how do we look at it in terms of prevention and control? So I've mentioned about the United Nations Sustainable Development Goal. If you focus your attention on good health and well-being, one of the aims is this: as a reflection of the United Nations Millennium Development Goal, they continue to address AIDS, tuberculosis, and malaria as the big three. But now they added your neglected tropical diseases, some of which are vector-borne, hepatitis, which we have already discussed, hepatitis. If this is hepatitis A, it could be vehicle-borne. Waterborne diseases are also vehicle-borne. So if you will notice, that is why I had to discuss communicable diseases in general, because the global direction is to address all of these. So I will now focus on the big three because these are some of the things that are of public health concern. Although our lecture for today will prioritize vector-borne, vehicle-borne, waterborne diseases, it is imperative that you understand other priority concerns from a global international public health perspective. Let's start with malaria. So, these are some of the goals of the malaria strategic plan, the malaria control program. And of course, we are hoping to eliminate malaria by 2030. Again, when I say eliminate, you want zero incidents with active intervention being done. Whether we're advocating for vaccines, whether we're doing public health intervention, it's something that we do from a public health perspective. So in the Philippine archipelago, the concern for malaria is most commonly seen in Rizal as well as in Palawan. In Palawan, in particular, some of the problematic areas would include Balabac, Bataraza, Brooks Point, and Rizal. Now, I want you to do supplemental readings on this now, but basically, we are advocating for different strategies to control malaria. If you will notice, one of the public health initiatives is insecticide-treated mosquito nets or your insecticide-treated kulambo. Your kulambo is often used sa gabi. Diba? When you sleep, you use the kulambo because remember, your Anopheles is a night-biting mosquito. We do not advocate insecticide-treated mosquito nets for dengue because you don't use the kulambo during daytime. And your dengue mosquito, which is your Aedes, would most probably do a blood meal during the daytime versus the nighttime. So if you look at the strategies employed from a public health perspective, these are just some of the things that we do. Or early diagnosis and prompt treatment. These are some of the key strategies that are being advocated now by the National Malaria Program of the Philippines. So, in terms of uh, empowering the community, it has to be an intersectoral approach, a multidisciplinary interprofessional collaboration to holistically manage malaria. So, malaria, since we are focusing on vector-borne diseases, we can look at it at different levels of prevention. When we talk of primordial level of prevention, we are trying to do is avoid onset of risk factors. And this was exemplified when we started to come up with policies. So even the policies, the planning started in 2015 all the way to 2030. The planning is being laid for all of us to follow. Because even for those without risk factors, we don't want the malaria to become prevalent. We'll also talk about uh, addressing vector bionomics. For example, how do we address the mosquito vector, the use of insecticide treated nets, indoor residual spraying, or different types of approaches have been recommended to ensure that malaria will not be passed on from one generation to the next. In terms of primary level, we are now looking into um, conferring specific protection against malaria. In the Philippines, the predominant species that causes your malaria would be your Plasmodium falciparum. And we are now advocating for chemoprophylaxis. If you are traveling to Palawan, let's say as a tourist, you want to see the Butesque um, underground river or subterranean river of Puerto Princesa, we would recommend that prior to your travel, you get yourself chemoprophylaxis. So you can give doxycycline before, during, and after your travel to Palawan. You also get treated for as part of your chemoprophylaxis. Early diagnosis and prompt treatment would comprise your secondary level of prevention. For the medical technologists in the group, you have been taught how to perform thin and thick smear, but now we are advocating for the use of your malaria rapid diagnostic tests, because in areas where there is lack of registered medical technologists, at least your RTDs can help in the diagnosis. And once confirmed, or once there is a presumptive malaria, you can already initiate early treatment using your artemisinin combination therapy. And some of your patients can develop severe types of malaria, including your cerebral malaria, and for which these patients would require rehabilitation, which would fall under your tertiary level of prevention. Again, cognitive rehabilitation for patients who suffered from severe cerebral malaria would benefit from rehabilitation and physical therapy, occupational therapy, speech therapy, behavioral therapy, among other things. Now, though this is not part of the topic, I want to briefly discuss the National Tuberculosis Program as well as HIV/AIDS, because these are the two other priority big three infectious diseases that our country is being plagued with. So when we talk of tuberculosis, we look at it from a public health perspective, and we really want to end tuberculosis the soonest possible time. How do we control tuberculosis? Of course, from a primordial prevention, we identify who are the risk factors, and there are many types of health awareness campaign that we can advocate for if you want to develop protection, even for those people without risk factors yet for tuberculosis. From a primary level of prevention, neonates, a newborn, a newborn before being discharged from a hospital or from a birthing home would require two vaccines at birth: your BCG for the prevention of your extrapulmonary tuberculosis, in particular your TB meningitis, and your hepatitis B. And if you will recall earlier on, I talked about why it's imperative that we prevent hepatitis B, because this is the first vaccine preventable malignancy that has been identified. So in the expanded program on immunization upon birth, two vaccines are already administered to our babies or to our neonates as part of the prophylactic regimens as primary level of prevention. For children, especially who might also have primary complex or primary cox infection, we can also give latent TB infection chemoprophylaxis, preventive isoniazid therapy. And then for the early diagnosis, of course, you want to do systematic screening for active tuberculosis. And the recent guidelines of the Philippines Department of Health in the identification of tuberculosis, we are advocating for active case finding as well as for intensified and enhanced case finding. For academic purposes, I will leave this as reading material for you guys. And then once you are already suspecting that a presumptive tuberculosis patient is really indeed if a patient has the active TB disease, we are now advocating the early treatment of your quadruple anti-cox therapy. For your quadruple anti-cox, for the pharmacists in the group, you are familiar with your isoniazid, rifampicin, pyrazinamide, and ethambutol. Most pulmonary or extrapulmonary tuberculosis would require 6 months of your anti-cox therapy. The first 2 months, which we call your intensive phase, would include 2 months of the quadruple HRZE. Then the next 4 months, from month 3 to month 6, we call this your continuous phase, wherein we now remove or we discontinue your pyrazinamide. Then we move on, as well as your ethambutol, and we just give your isoniazid and rifampicin. So in totality, this would require 6 months of anti-cox therapy, 2 months of quadruple intensive phase, and 4 months of continuous two anti-cox medication. Tertiary level of prevention would entail for extrapulmonary tuberculosis. For example, for those who develop TB of the bones, we refer to this as your TB of your Pott's disease, or it could be your TB meningitis. So they will also require physical therapy, rehabilitation. Some of the patients that I handled with Pott's disease during my residency years, children would be paralyzed because of the involvement of the spine, and there is impingement of the spinal nerves in the vertebrae, and so they would require intensive physical therapy for them to regain the ability to walk, as part of the tertiary level of prevention rehabilitation for extrapulmonary tuberculosis. Then the last would be your HIV/AIDS prevention and control in the Philippines. This is something that is of public health importance. If you look at the global burden of HIV/AIDS globally, there is a decline in the cases, except in the Philippines and 5 other countries, wherein there is still exponential increase in your HIV/AIDS. And why is this relevant in the Philippines? Because we are seeing a 411% increase in daily incidence of your HIV. And sadly, there is a portion of these individuals who already manifest with advanced HIV disease. Some of them are even diagnosed to have acquired immune deficiency syndrome already. And the sad reality is we're seeing younger and younger population members to be afflicted with their HIV. Look at this. If you look at the numbers are a bit alarming. Most of your in terms of the links of infection, the links to the chain of infection, the mode of transmission remains to be direct through sexual intercourse or sharing of infected needles, and to a certain degree, vertical transmission from a pregnant mother to the growing fetus. So these are the latest data that I was able to gather for 2025 in terms of the public health burden of HIV/AIDS. I want you to read on these. I will leave this as reading assignment for you guys, but I just want to highlight here that from a public health perspective, what do we want in terms of HIV/AIDS control? We want 95, 95, 95, U equals U. What does that mean? Among all of those who are sexually active, we want 95% of them to have themselves tested and know their status. So, of the sexually active people, 95% of them will undergo testing or screening for HIV. If you are already positive for HIV, or you are HIV reactive, we want 95% of these people to be started on your antiretroviral therapy. So we want them to receive treatment already. And hopefully, once they have already started the treatment, 95% of them would have viral suppression. When you say they are virally suppressed, there will no longer be any detection of your HIV in the system of that individual. Because once the HIV is no longer detected, then you are no longer capable of transmitting it. That is the 95, 95, 95. U equals U. 95% of those who are sexually transmitted will know their status. Of those who are HIV reactive, 95% will be started on antiretroviral therapy. And we want 95% of these people will be virally suppressed. Because if undetected, untransmissible na ang HIV. Kaya U equals U. Undetectable, untransmissible. That's the general goal, whether you are here in the Philippines or in Africa. Another type of intervention that we are advocating for will be the use of your pre-exposure and your post-exposure prophylaxis. I will again leave this as reading material for you, but basically, when we talk of pre-exposure prophylaxis, we are now advocating the use of your emtricitabine and your tenofovir as daily medications for people who do not have HIV yet, but for one reason or the other, they are at risk of acquiring the infection. So kahit wala pang HIV, we are already advocating for PrEP. Even before the exposure happens, you are being protected already. That is your PrEP because you are at risk. You are a high risk individual. Then we also have your post-exposure prophylaxis. In the Philippines, this is reserved for victims of sexual assault or for healthcare professionals who have sustained needle stick injuries. Let's say you're doing phlebotomy or blood extraction on a PLHIV and you accidentally injure yourself with the syringe that you use to extract the blood, then that's the time we recommend your post-exposure prophylaxis, which is a 28-day regimen utilizing your antiretroviral therapy. So there is a difference between your pre-exposure and your post-exposure prophylaxis. For academic purposes, I will just leave this for you guys as reading materials. Now, remember, we said 95, 95, 95, U equals U. That is the goal from a public health perspective, from a global vantage point. That is what we want. But how are we faring in the 95, 95, 95, U equals U? The numbers are a bit disappointing. As of June 2025, according to the Epidemiology Bureau of the Department of Health, only 57% undergo testing. Only 66% are started on antiretroviral therapy, and only 47% achieve viral suppression. So this is very far from the target 95, 95, 95, and we only have 57, 66, 47. Very far from the ideal target of U equals U. So again, I'm leaving this for you for academic purposes. You can read on this. Look at the numbers. Sad, as of 2025, as of June 2025, we are seeing 55 new cases of HIV every single day. That translates to 2 to 3 newly diagnosed individual every hour. And look at the numbers. 46% of these individuals would belong to the 25 to 34 age group, while 34% would be the 15 to 24-year-old age group. If you lump them together, this is basically about 80% of the Philippines, the population among the PLHIV that are getting HIV/AIDS. That's basically your age group. So the burden of HIV is a problem that is prevalent in your age group, the 15 to 24 and the 25 to 34. And most of these are usually among the males who engage with sex with other males. So again, I'm just giving you more literature to read when it comes to the burden of HIV/AIDS in the Philippines. NCR and Region 4A are the countries which are considered hotspots in terms of the new cases of HIV/AIDS. So what do we do from a public health perspective? We now have Republic Act 11166, or the Philippines HIV and AIDS Policy Act. In a nutshell, what is new about this is that we are lowering the age for testing of HIV. In the past, you need to be 18 years old and above to get tested for HIV. But with Republic Act 11166, as early as 15 years of age, you can already get yourself tested even in the absence of parental figures for HIV. In the past, we are seeing children engaging in sexual activities as early as 11, 12, 13 years old. They're sexually active even during pre-adolescent years, but they cannot get testing for HIV until they turn 18. So there is a 5 year, 8 year gap from the time they start, 5 to 6 years, 5 to 8 year gap from the time they start getting to be sexually active until the time they get the legal right to get themselves tested. And that is why the age for testing has been decreased from 18 to 15 because of Republic Act 11166. So we talked about already the use of your pre-exposure and your post-exposure prophylaxis. And of course, just to give you more reasons to more reading materials. Primary prevention, of course, we are now advocating for awesome threesome, pre-exposure prophylaxis, HIV testing, and of course, the use of condoms whenever you are engaging in sex. We are advocating for protective type of sexual intercourse. And because the most at risk population would include the LGBTQIA plus community, even for the transgender population for HIV prevention, we are now looking into GAT, your gender affirming hormone therapy. These are just some of the interventions being advocated now as part of the primary level of prevention for HIV/AIDS in the Philippines. For academic purposes, I would prefer that you do supplemental reading on this topic. Secondary prevention, we are now looking for early diagnosis and prompt treatment. We are now also exploring the use of your rapid diagnostic tests in the diagnosis of HIV. So, in the latest algorithm, this is how HIV is now being tested or at least being screened for in the country. And for treatment, of course, we are now looking into different types of antiretroviral therapies. The latest of these would be the introduction of your dolutegravir in 2020 in the Philippines. And for tertiary level of prevention, we are also advocating this rehabilitation and psychosocial support for people living with HIV as well as for their significant others because it can inadvertently impact on one's mental health. So, in summary, what have we discussed? Again, I focused on control and prevention of communicable diseases in general, but for the topic assigned to me, I am focusing on vector-borne and vehicle-borne infections. But we have discussed the chain of infection because knowledge of the chain infection would allow us to come up with preventive and control strategies, breaking the links of the infection to address the public health burden of communicable diseases in general. We talked about food safety, security, and other food preservation issues. So these are just part of the preventive measures, food safety, nutrition, and food security. We likewise also talked about the United Nations Sustainable Development Goals. We've talked about vector-borne vermin-related diseases, the use of protective measures, whether we are doing immunization, chemoprophylaxis, community mobilization, including environmental sanitation, and highlighting what are the priority concerns of the United Nations Sustainable Development Goals. We had a brief discussion on malaria, tuberculosis, HIV/AIDS, and your NTDs. But again, when you go into higher medicine courses, internal medicine, pediatrics, microbiology, parasitology, or even pharmacology, you will have deeper understanding or deeper discussions on these communicable diseases. So for the lecture, these are some of the references that I used. And if you want to do supplemental reading, I will highly encourage that as well. So with that, thank you very much, and I appreciate your kind attention.